and get some inside information as to what prompted the study, how the study was done, and the future directions of the work. Jason Sheehan won't be joining us today, but Randy and I are here. We'll be asking some questions of our guests, which is Professor Yori Gidron and Rachel Grossman from Haifa, that are going to talk to us today about the prognostic and protective roles of heart variability and glioblastoma, making GBM less vague. And I'll remind our participants that are in real time watching us to utilize the chat function to type in any questions, and we'll get to them once the presentation is over. So with that, take it away.
You want to share your screen?
You want to share your screen?
Oh, sorry, I wasn't sure. I thought somebody's going to talk before me. All right. Shall I begin?
Please.
Okay. I'm just going to put it on presentation mode. Can you guys see? Is it okay? Okay.
Yep, looks perfect.
First of all, I want to thank my dear colleague and friend, Professor Rachel Grossman, for this invitation. And for your journal. I think it's a big honor. It's actually one of my first webinars that I'm being invited to speak at. I presented this in many, many places, but not in such a format, so I'm really honored. And I've been working on this topic for about 20 years already. And when I met Rachel about 5 years ago, it was the first time that we began to think about this in brain tumors. I'm a professor of health psychology. I'm not a physician, but my work is very, very medical, more medical than psychological. So I don't need to tell you anything about glioblastoma. I think you all know much more. I'm sure you know much more about than I do. But I think that one of the challenges is because the survival is so grim, it is calling us for a challenge to look for not only other risk factors, but more importantly, protective factors. And I think it's very challenging because of these three reasons. And I'll get back to the issue of the protective BBB later. So many cancers develop because of these reasons. Oxidative stress and DNA damage, inflammation. Inflammation is a big, big player. A lot of people do not know that sympathetic hyperactivity is very crucial. In fact, some studies show that the region to where metastasis goes and migrates is driven by norepinephrine, hypoxia, as you all know, and on the other hand, anti-cancer immunity seems to have a protective role. So, as you know, the immune system has a double-edged sword in cancer. Now, the question is there one factor that actually can play a role against the first four and encourage the last one? So it would be much more parsimonious and useful and economic if we find one factor that influences for the better all of these. So with all modesty, I would like to propose that this is the vagal nerve. So people think that I research heart rate variability. No, I'm investigating the vagus nerve. We are. And it's marked by what's called heart rate variability. So these are the little small changes in the x-axis in the intervals between normal heartbeats. These are normal heartbeats. It's not arrhythmia. It's not anything abnormal. These are normal heartbeats, and it changes. It's almost like the vagus is the accordion player of the ECG. Okay, it's playing on the x-axis. And the more you have change between interbeats from age 0, from neonate, all the way to elderly, actually predicts survival in many, many epidemiological studies. So the greater the variability, it is a sign of adaptability. The vagus is inversely related to oxidative stress and also reduces, vagal nerve stimulation reduces in oxidative stress. The vagus reduces inflammation. There's a whole domain called neuroimmunology, and the vagus inhibits inflammation by two routes. One of them is by the HPA axis, producing eventually cortisol, which is anti-inflammatory, as you know. And this has all been discovered by Kevin Tracy's group in New York. And the other route is by the by the spleen, and there's been some T cells there that have been found to be sort of like the ambassador of the vagus in the spleen. They receive a sympathetic input, and then they produce acetylcholine, which then tells macrophages in the spleen stop producing inflammation. And the vagus, of course, is parasympathetic, therefore it reduces sympathetic activation. HRV is positively related to SpO2, so that's how it would have an anti-hypoxic effect. And most importantly, in addition to its anti-inflammatory role, several studies show that it actually enhances the good side of immunity. So if you if you do vagotomy, you can have reduction in NK cells, but if you activate the VEX, you have increases in NK cells, and similarly also in CD8 cells. So these are both anti-tumor immune cells. And this is what put me in a long time ago to propose, this is before we knew all those mechanisms, to propose that the vagus might inform the brain about peripheral cancers and then slow them down. This is before we even thought about brain tumors. And this is why we think it is. It's reducing all of these first four fellows: oxidative stress, inflammation, sympathetic activity, and hypoxia, and increasing anti-cancer immunity. And we have quite a bit of evidence for most of these. So I'm going to show you some preliminary data, some past studies we've done, and then the study that we published in your distinguished journal. So we've done a study in Brussels where we looked at eventually 272 patients with advanced stage 3+ and stage 4 metastatic pancreatic cancer. And we found that a simple ECG of 10 seconds, if you derive from that heart rate variability, it predicts a doubling of survival. So higher HRV, doubling of survival in this terrible cancer, in pancreatic cancer. And this was independent of several confounders. So even after controlling for all of these confounders, higher HRV, one of its markers is called destinant, lower risk of death. And here we found indeed that the mechanism was by less inflammation. In another study that we did in Israel, in Tel Aviv, we found in diffuse large B-cell lymphoma, to our surprise, that in a small cohort of about 32 patients, they were all very homogenically treated with a CAR-T treatment, sort of like an immune treatment, higher HRV, again from a ridiculous 10-second ECG. I'm on purpose saying ridiculous 10-second ECG. So this is a mundane ECG taken around the world in many places, and there's gold over there. So even from this 10-second ECG, almost 5 times the chance of living this B-cell lymphoma compared to low HRV. And again, independent of confounders. So then we decided, I met Rachel, and when she moved to Haifa, we decided to relaunch this study. And we retroactively looked at 53 patients with glioblastoma, their ECG, obtained near diagnosis. And their mean age was about 65. And we, in the full sample, we did not find that HRV predicted survival. But when we split the sample into below 65 and above 65, we found what we expected. In fact, in lung cancer, we also found in a previous study that below age 65, higher HRV predicts better survival, but not in older patients. So we wanted to replicate this here. And indeed, of course, age predicted more dying. Karnofsky predicted survival, extent of resection. But again, HRV predicted better survival in those patients that were below 65. And this is a survival curve. You can see higher HRV, about doubling of survival compared to low HRV, only in patients below age 65. So we're very happy about this, but not in the older age group. In the older age group, the lines were almost overlapping. We then looked at something else. We psychologists like to look at what's called moderation. So moderation is when you look at X as a predictor of Y, But then you look at another variable and, well, maybe X predicts Y, but only in men and not in women, or only in young and not in old, or only in people with progesterone positive and not negative. So all those other third variables will be a moderator. So here we checked whether heart rate variability is a moderator. So we divided the people into low and high HRV based on published norms in cancer. And age predicted more death. These are just Spearman correlations in both groups, low and high HRV. But Karnofsky predicted less death, so higher Karnofsky performance, almost significant lower death, but only in low HRV, not high. Similarly, extent of resection, you higher extent of resection, less death, but only in low HRV, not high. So it seems as if the higher HRV is sort of like protecting us. It's blocking, it's moderating, it's weakening the effects of these adverse factors. And we find this in several cancers. In the other study that I showed you with the B-cell lymphoma, we also found that the patients that had relapse, all of them died, well, only if they had low HRV. If they had high HRV, again, only 37% of those who had relapse died. So again, this high HRV seems to moderate, weaken the effect of other risk factors. So just to summarize, for now, higher HRV indexed by, which is an index of the vagal nerve, independently predicted prognosis in glioblastoma, multiform, but only in the younger patient group, not in the older ones. And saying this cautiously, this is not a causal effect, but higher HRV might moderate, might weaken the prognostic effect of at least extent of resection in glioblastoma and maybe also of Karnofsky. Of course, the limitation of this study was that it's a small sample, it is retrospective. In fact, the formal name of it is historical perspective, but we'll still call it retrospective. And of course, the ECG is very short. So we need to replicate this in a larger sample, do it properly prospectively, where we'll have more control on how to measure everything and on confounders, and also measure the ECG longer. So where can we take this to? I think all of you are clinicians and I'm a simple scientist. So nevertheless, I'm a translational researcher and I'm looking at how to help people as well. And so there are several ways to enhance vagal activity. One of them is by medication, but I'm not a physician, so I'm not going to talk about this. But we can do it by biofeedback and by electric stimulation. So I'm just going to mention briefly, what is biofeedback? You measure some kind of factor of the body, you show it to a person on a screen, and you teach them to influence that variable, that factor. So in this case, you measure HRV on the finger. You just need a pulse. And again, the interbeats between the pulses and their standard deviation is the HRV, is a vagal activity. You teach them to do slow-paced breathing, like 5 in and 5 out, or 4 in and 6 out, doesn't matter so much. And they can see very quickly that their heart rate variability is going up. This has been shown in many studies to reduce anxiety, post-traumatic stress disorder, inflammation, and also in cardiac patients to reduce hospitalization. So this is a small pilot study we did in Brussels, and I'm ashamed to say only with 6 people. It was very hard to recruit these people. They all had metastatic colon cancer. And what we did was so the experimental patients had stage 4 colon cancer, and they did 3 months of 20 minutes a day HRV biofeedback, and they also got chemotherapy. So then we matched them to 3 controls that had the same. They all had stage 4 colon cancer, the same line 1 treatment, and we also matched each one on their baseline CA, the tumor marker. But the controls did not do biofeedback. And let's look at what happened to their tumor marker. As you can see here, this is the tumor level at baseline. And over time, in orange, these are the controls. They just got chemotherapy. The tumor marker hardly changes. But in the red, it's a tumor marker of the people that get chemotherapy plus biofeedback. You can see the CA dramatically reducing. Of course, this is just a small proof of concept study. So our next study that we hope to do, I want to do with Professor Grossman, is to do a larger study. Sorry, I forgot, not in visceral cancers, but we're planning to do this also in visceral cancers, but also in brain tumor, and to randomize them to usual care or usual care plus HRV biofeedback and look at various outcomes. That's one future study. And the other one is bivagal nerve stimulation, as one of you have asked me initially. So you can actually stimulate the vagus in the ear. There's some vagal afferent fibers in the concha and tragus. And this has been used to treat migraine and tetanus and other things. Or you can stimulate it here in the neck. This is by Gammacore on the left side, and it's really in the just next to the carotid complex. This has been shown to reduce inflammation, to reduce post-traumatic stress, and other things too. And I'll just show you a small study that we did in cardiac patients, where we randomized patients. This is a doctoral thesis student of mine, Riham Diab, together with the head of cardiology, Edith Dubrovsky. We randomized people after ST elevation myocardial infarction to usual care or usual care plus transcutaneous vagus nerve stimulation, and immediately after catheterization. And these were all our outcomes. I'm not going to tire you. And we showed a greater reduction. The change in the troponin was much faster and larger in the experimental group. And there was a significant increase in left ventricular ejection fraction. So these are new findings, very preliminary, and voila. So our future is also to examine whether this could actually improve prognosis in glioblastoma multiforme. And one could speculate what would be the mechanisms of vagal nerve stimulation. There is evidence that vagal nerve stimulation reduces inflammation also in the brain and might also make the blood-brain barrier more permeable, which is one of the protective factors against treatment in multiforme and in GBM. So this might reverse that. So these are some of my speculations about any possible effects of vagal nerve stimulation, electric stimulation in brain tumor. Voila. Thank you so much for this invitation. And I'm happy to open this for questions. And if Rachel, if you want to add anything, please do. Thank you.
Thanks so much, guys. Rachel, anything to add before we dive into some questions?
I just thank you, Yori, for a great presentation. I just, the idea is to find other parameters in this terrible disease that we as physicians can actually change. We have the age rate, the KPS, we have the MGMT mutilation status that we cannot control them, but we do want to think that we can control the extent of resection, but not always, because if we are deal with a very extensive and multifocal disease, we cannot really perform a meaningful resection. So I think identify a new parameter such as the HRV that actually represent the vagal activity is very interesting. New player in the field of surgical or not surgical neuro-oncology, treating a patient with brain tumors. So I think it's very promising new aspect of that we should explore in the future.
Yeah, great presentation. Thank you so much, Dr. Grossman. Thank you so much, Dr. Gidron. I chose this article. I find it very provocative. I work here at Northwell. The Feinstein Institute is part of Northwell, and Kevin Tracy is a neurosurgeon who went into research because what he found with the vagus nerve was so intriguing. And actually, I actually have a meeting with him tomorrow at 4. I'm giving grand rounds over there, and so I read.
Please send in my regards.
Definitely, I just read his book, The Great Nerve, which is, a good summary of kind of all the work that his lab has done on this. And I myself have become very interested in functional health and kind of the contributions. And, it's just very provocative because I measured my heart rate variability, and mine average was about 45. I'm a 44-year-old guy. I have a fairly high stress job, right, Dr. Grossman, right, Dr. Cifarelli? And I wondered, well, how do I make it better and what's it really doing? And then your paper came out And I started diving really into this, and it's super, super fascinating. We have a great question. What do you define high versus low? Mine's 44. I know my 30-year-old nurse's is 75, her heart rate variability, as her Apple Watch tells her. My wife's is like 11, which is not so great. But yeah, exactly. So what do you guys define as low and high? And what are, how are you guys keeping yours high?
Can I answer, Rachel?
Please,
Okay.
dive in.
So, there are about 20 different parameters. There's not one. So that's the hard news. So there are many, many different parameters. Assuming that what you're talking about, usually you have it on phone apps or on watches, right? Is either what's called SDNN, the standard deviation, or RMSSD. And their numbers are about, you want it to be above 50, more or less, or over 40, over 50. It depends on which parameter. And these are age related also. So assuming based on your looks, your HRV normally should be higher than mine. But here's the good thing. So the hard thing is that it's about 40 to 50% of it is genetically driven. So we cannot influence it so much. But on the other hand, 40 to 50% of it is environmentally driven. So Mediterranean food, come and eat our great hummus and salad. Again, Mediterranean food, exercise and non-smoking. So a healthy lifestyle increases HRV, and yoga and paced breathing. So all of these things have been evidence-based, shown to increase HRV.
Yeah. So the one thing I find interesting in the book, in The Great Nerve, he talks about how cold plunges. He hasn't fully embraced it yet, but he does take a cold shower, probably a couple times a week. And I'm just curious if you guys have seen differences in those, in those as well. Which ones do it more or less?
There's a whole thing called the Wim Hof method. It has been investigated. I don't want to say too much about it because I'm not too aware of it too much, but there is evidence that cold water, and that there are studies also showing that the Valsalva movement and cold water on the face actually increase HRV.
Yeah,
indeed.
Yeah, so thanks. That was a wonderful talk. I did want to get to ask you some specifics, though, just about inclusion in this particular study. And I didn't see it in there, but the fact that the effect was only preserved in younger patients, what was the IDH1 status? Is that available for these patients? Were there any IDH mutants potentially mixed in here, or are these all WHO grade 4 GBM as defined by IDH wild type?
So all of them were purely IDH wild type glioblastoma, newly diagnosed. So because it was a pretty small cohort of 88 patients, it was extremely important to keep it as much as homogeneous as possible. And that's why we did not mix recurrent and just purely newly diagnosed.
Yeah, and I think this data really does speak to the fact that GBM, much to the chagrin of all of us, is really a global disease in the brain, as much as we try to fight it locally. And I think only by targeting things like vagal input and more global neuroinflammation are we going to be able to advance beyond where we are already. Because to be honest, we've been down the path of gross total resection, super total resection, optimizing radiation fields, tumor treating fields. Now we're going down the pathway of immune checkpoint inhibitors. So where do you see the next step? Do you think that there is a possibility in the future that an implantable vagus nerve stimulator would be something that would be effective for a GBM patient to slow down progression in this dismal diagnosis, and much akin to what we're seeing in stroke recovery patients who are seeing benefit on trial so far for VNS?
So I totally agree with you about the idea that GBM is a disease of the whole brain, and we need to think about it like something that we treat it as a systemic approach rather than locally. I mean, we can definitely do mass debulking or resection for patient because we know it's correlate with prognosis. but we also know that we cannot cure this patient by surgery or radiation alone. So I think these modalities that were proven in other type of cancers, the idea to implant or to incorporate them in the neuro-oncology context, I think it makes a lot of sense. But we are not there yet. We just got the idea that there is something in it. I mean, we took the concept for other field in cancer research, in the other field of oncology. I mean, it was proven in non-small cell, in pancreatic cancer, in a lymphoma. And we saw that there is a hint, there is something also in GBM patient. And I think that it gives us the idea that this is a very interesting and promising direction to continue and to explore. And then you can, get the inspiration or idea or, from other field in neurosurgery, such as functional neurosurgery. And then you can, plan and try to see what is the right device, how to continue from this point and do and to maximize the effect of this patient. So, yeah.
If I may add, I fully agree with what Professor Grossman said. I think before running into an RCT on vagal stimulation, I would want to replicate this in a larger sample and do it maybe prospectively. And if we can substantiate this, and I'm inviting people here to maybe do a multi-center trial with us, that would be amazing, or multinational, and a longitudinal study. And then if we can replicate what we found, then I would feel more confident to do an RCT. Interestingly, you asked about implantable. I mean, I'm not a physician, so I would be more cautious and go first for the non-invasive one. But of course, probably doing an invasive one would reach the fellow directly, the vagus nerve directly, so the impact might be stronger. But again, it could have other consequences. So I think caution is important here. But that's my approach.
Yeah, I think understanding limitations of the study. Again, it's still a very provocative study. I think that the historical context you put it in with regards to other cancers, whether glioma is the right cancer to look at the SIN versus metastatic disease versus other things, are questions for the future without a doubt, and whether implantable or external, also future questions. What I find fascinating is just the implications for even the etiology of the disease. You see the younger people with lower heart rate variability doing worse than the older people. And the older people, we know heart rate variability goes down. And so you start to lose that, functional youth maybe based component of benefit. And so I think it's just, overall really fantastic, thought-provoking study. And I can't wait to see what you guys come up with next, the bigger data. So we're about at 30 minutes. If there's no other questions from the group, Chris, any last comments?
No, I think this is great work, and I think trying to change the paradigm of just focus so much on local disease and expanding it to a systemic treatment approach is welcome at this point. So I thank you for your work, and we look forward to your future submissions to JNO.
Yeah.
Thank you very much.